Well, good afternoon. It's nice to be with you again this afternoon. This afternoon's panel focuses on the recent cutting-edge work of several of our major federal healthcare organizations and agencies, specifically the Veterans Administration and the Indian Health Service. In that regard, we're fortunate to have with us this afternoon Dr. Adam Darkins, who leads the National Telehealth initiative for the VA for nearly 12 to 13 years, if memory serves. Bringing to that effort a breadth of experience, both intellectually as well as programmatically, from his work internationally. We're also joined this afternoon by Dr. Mark Carroll, who recently left after a full decade's work with the Indian Health Service to join the Flagstaff Medical Center, and particularly there to direct their program in population innovation. Among his roles in the Indian Health Service, Dr. Carroll led the planning and conceptualization of the telehealth initiatives nationwide for the Indian Health Service. And last but not least, we're joined as well by Dr. Jay Shore, who is an associate professor at the University of Colorado in Denver, the Centers for American Indian and Alaska Native Health. He also is employed by the DoD's TATRIC, that's the Telemedicine and Advanced, I can never remember what that always means, Research Center. There's another T in there. And he's also works for the Veterans Administration in their native domain of their Rural Health Resource Center. This is really a unique opportunity to have the perspective of two federal agencies which work independently of one another for the most part, but have a formal memorandum of agreement dictating the ways and encouraging the manner in which they ought to work cooperatively to serve the veterans of mutual interest. Dr. Shore's work is at the interface of those two in the application of such efforts and attempting to bridge on an operational basis such a memorandum of agreement. And so today's panel is intended to provide us with greater insight into these particular federal healthcare organizations' approach and current thinking and future challenges with respect to the role of telehealth in their specific enterprises, and also to begin to highlight for us some of the challenges and opportunities that emerge with respect to collaboration across federal agencies in service of particular segments of our population. So we'll begin with Dr. Adam Darkins, move to Dr. Mark Carroll, and conclude with Dr. Jay Shore. Adam.
Well, good afternoon, everyone. I'm very glad to be here. Let me start for 1 second with a couple of personal notes. I firstly got involved with telehealth back in the mid-1990s. I worked for a startup healthcare organization. My reason for doing so was it was a way to solve problems. So what I'm going to talk to you is going to come with that perspective. I also was involved with a startup technology company around the same time. And one of the things that came very clear to me in my way of thinking at the time, that the future of this area of telehealth that was going to solve problems was around developing large networks. Now, by the definition of telehealth, the one that was raised yesterday, the Institute of Medicine definition, information and telecommunication technologies to deliver healthcare when patient and practitioner are separated by distance. We've had a telehealth network that's been around for over a century, which is the telephone network. So I'd put to you that if you look at the experience of that, all that's currently being talked about is going to happen. So it's not a question of whether this will happen. The way of technology is it will become ubiquitous and people will use it. So I would put to you the issue is not about whether it'll happen, it's how it'll happen. So I feel very privileged indeed to work for the organisation I do, the Department of Veterans Affairs, and by great luck came to work with them. And so what I'm going to describe is the work of many individuals over years, and it's actually building on things to take us there. The First thing I was going to say is just describe quickly what I mean by telehealth in terms of what I'm going to talk about today. I won't go in detail through these, but home telehealth, clinical video telehealth, store and forward telehealth, teleradiology, secure messaging and mobile health are all elements of telehealth. And the slides are available, so if you want to go into more detail. What I'm going to talk to you today is about three elements of this: the clinical video telehealth, the store and forward, and the home telehealth. One of the things, from my point of view, about developing telehealth services is it has to be based on a demonstrable patient need. For the organisation I work in, it makes great sense to do this, to focus very much on the veteran delivering care. It's looking forward into the future what service will be done, but very much around the results. So the organisation has introduced telehealth not because of an interest in telehealth, but primarily an interest in providing care to a population and a population of veterans. The first area I'm going to talk to you about is home telehealth, which I'm sure many in the audience are familiar with. From the point of view of the VA, the value in delivering home telehealth is, as you've heard already, dealing with people with chronic conditions. There's no evidence that dealing with long-term chronic conditions, the traditional outpatient clinic, is the most effective way to do it. How we have introduced it is to provide non-institutional care, keeping people out of nursing homes, chronic care management for expensive patients, acute care management, health promotion, disease prevention. We use off-the-shelf technologies and have a dedicated national telehealth training centre, which I'll talk about, that trains staff. Standardised business processes, because essentially when I talk about developing large networks, networks need to have standards and interoperability. We currently are providing care to just over 74,000 people as you're sitting here and I'm standing. The growth I can show you from fiscal year 2008, that's at any point in time, that's the census of patients currently being managed. So we built up from originally in 2003, we started off at around about 800 patients and plan to be at around about 92,000 by the end of next year. The second program I'm going to talk to you about is store and forward telehealth. And this, again, the main areas that we do this for are teleretinal imaging for diabetic retinopathy and for teledermatology. So quickly to get to the patient need for this, I described the home telehealth, it's chronic disease management. In this population, the 5.6 million veterans, around about 20% of those veterans have diabetes. Screening for diabetic retinopathy is a way to avoidable blindness, to prevent avoidable blindness. So there's a large population that it makes sense to be able to driving this for. And the VA, as many organisations, particularly in rural areas, has difficulty with finding dermatology services. So teledermatology makes great sense. And with this infrastructure in place, we're also exploring actively how we move forward into wound care. So again, to give you some sense of how this has grown, from 2005, we started off at around about 1,500 patients, grew to 127,000 by fiscal year 2008, and last year, 171,000, and the end of this year, we're planning to be at 256,000 patients being managed. The third area I'll be talking about is what we call clinical video telehealth, essentially replicating a face-to-face visit. And that face-to-face visit enables somebody to see somebody without travel. The major areas we've done this for mental health, which I'll cover in a moment. We have a large dedicated national network, which we've built over the course of the last 7 years. There are now 4,000 video endpoints in the VA, everyone interconnected with each other by IP video. We're also extending this to do IP video into the home, the spreading out, and this is really an example of how these areas are converging. Though I'm talking about the three of them separately, they're actually actively converging as we move forward. Fiscal year 2008, 93,000 patients received care in this manner. This year it'll be at 200,000, sorry, last year it was 200,000, and this year it'll be at 308,000. So at this moment in time, the programs are roughly doubling every 12 months. So let me just drill down a little bit more on what these are. The clinical video telehealth services, predominantly very large population with mental health problems to deal with, as everyone is aware, if not from direct experience, but certainly from what's in the media. Telecardiology, teleneurology, women's telehealth, teleprimary care, spinal cord injury, amputation care, audiology, pathology, and moving forward actively as we the last year with tele-ICU. Home telehealth, the care and case management of chronic conditions, and also moving forward to do health promotion, disease prevention, particularly in weight reduction. And the store and forward, as I mentioned before, the retinal imaging, teledermatology, and telewound care. So VA is recognized as a national leader in telehealth. In 2011, these three areas I've just talked about provided care from more than 150 VA medical centers and 75 community-based outpatient clinics to 380,865 patients. The reasons for doing telehealth are reducing cost, increasing quality or improving access. 47% of the patients who are served by these programs are in rural areas or 3% in highly rural areas. And so this was very much one of the reasons to do it. One of the things I heard yesterday was some discussion around whether urban versus rural. Now, being a simple-minded soul and talking about networks, your resources to provide care in rural areas come from urban areas. So to my mind, this isn't a question of one versus the other. If you're developing a large network, you're going to serve your rural network from urban resources. So this is about developing a large network. As we move forward into this year, we plan that there'll be 480,000 veterans served this year, which is approximately 9% of the veteran population will have been served in some way by these three programs, by one of them. And next year, in fiscal year 13, that number will rise to 820,000, which is 15%. So the benefits of the organisation in doing so, very much I've talked about access in rural areas. We've got routine outcomes data, which we collect on these patients being provided. So for the home telehealth programs, we're seeing a reduction in bed days of care of 53% in these patients. And these are assessed, so these aren't just patients who get technology. They're assessed in terms of their need for non-institutional care by their ADLs and IDLs, and also for chronic care management. The clinical video telehealth, we've got data for mental health care that shows we're reducing bed days of care in the order of 25%. The home telehealth, we get 86% mean score and satisfaction. It varies a little bit year to year, but we're in the sort of mid-80s to low 90s. The store and forward telehealth, we get a 92% mean score for satisfaction, and we're just instituting the program to be able to look at the clinical video telehealth. VA pays a certain amount of travel costs to veterans. We're finding by virtue of looking at that nationally that we get $34.45 savings per consultation, and $38 for clinical video telehealth and $38.81 per consultation for store and forward. We're seeing previous years $1,238 savings for home telehealth per year, and next year in that, which is 2010, we saw $1,999. And those are savings above all other costs, cost of the program factored in. Just to drill down a little bit onto mental health being such a large reason for doing telehealth. Last year, 55,000 telemental health video patients, 140,000 telemental health visits, provided for 146 hospitals to 531 community-based outpatient clinics. 442 patients receiving care via video into the home, and home telemental health patients for PTSD, depression, 6,764. Some outcomes related to that. The study looking between 2006 and 2010 of the clinical video-based services, seeing a 25% reduction in utilization for the 98,609 who had been managed in that time. Home telehealth, looking at the 1,041 mental health patients reviewed before and after enrollment in the program in 2011, we saw that we were getting a 70% reduction, 3,262 bed days of care saved by virtue of using that program. Some unique challenges, which are not unique to us, but unique to telehealth. Its training's not offered in medical schools or included in health professional curricula. No outside resources to train VA providers on the kind of scale we're talking about. More than 60 requirements exist to establish a telehealth program. So the devil, as I so often say, is in the detail. The vision of this is complicated but relatively easy. The devil is in how you make it happen. And so 60 requirements need to be done for an average program to be put up. Joint Commission doesn't survey telehealth specifically, but during its tracer methodology, we're now doing such volumes that is coming across telehealth all the time. So it is important that we end up thinking about Joint Commission inspections. We have 3 telehealth training centres that were developed to provide standardised training, a quality management team that does biannual reviews of each one of the VISNs. They're the Veterans Integrated Service Networks that provide the operational delivery of services around the US. We have national databases for reports and analysis and metrics, so the routine data that we get is provided locally to substantiate for these local VISNs and for local VA medical centres what the benefits to these centres' sites are to be able to having these services. We have national contracts and contract support for telehealth technologies, including service and warranty, and to ensure equipment quality and safety. We collaborate with national clinical experts, develop and provide standards for care via telehealth and guidance. And lastly, as any program will tell you, a big piece of this is how one deals with information technology and biomedical engineering to be able to make sure there's comprehensive cover for the services. Our training, the mission is the right training in the right place at the right time, which goes with the care. And in terms of a large network, it's important that people are trained in a systematic way. And we have quite a high turnover, not a high turnover because people come into the program and promptly want to leave. But actually, one of the really rewarding things about all these programs is quite a number of people are coming into the programs towards the end of their career in the VA. And to have people say this was the best job I've ever had in healthcare, and this is why I came into healthcare, is certainly one of the many gratifying things about having the program. The emphasis is on virtual training, strategic partnerships with our employee education system, and all to annual strategic plans for all the areas I'm talking about. I won't go through in detail other than to say we successfully plan, deploy and manage telehealth programs. We organise clinical, technical and business infrastructures. We assess programs to identify clinical needs that telehealth can address, improve and expand the delivery of care via telehealth to ensure it's efficient, quality and sustainable in the training, and integrate with existing programs. So some data on training through this fiscal year, FY12, in the third quarter. We've had 150 training courses or forums available from the 3 sites. The clinical video telehealth has done 2,500 unique staff trained via 800 training events. The Store and Forward National Training Centre, 3,200 unique staff trained via 250 training events. And the Home Telehealth, 2,500 staff via 800 training events. And 98% of this training is done virtually. There's no point in having to pull somebody all the way from Montana down to Denver or fly them to a national centre to train. So we have 3 centres, they collaborate, they have slightly distinct areas, but they're converging in terms of what they're doing, much as the technology is. And some of the training innovations, clinical practice forums, integrated telehealth master preceptors programs, interactive meeting rooms, new and improved methods of training, pre-test test-out option for super users, video used to capture the human element, scenario-based instruction evaluation, animation used for technology instruction evaluation, and rapid response training. I'll finish on one note. When I was a medical student, I went to the south of Ireland and I was taught by a professor of surgery. He came back at the end of being abroad, and we did rounds. At the end of the rounds, he said to me, "Did you notice I touched every patient?" And he washed his hands. There was no issue with control of infection. He said no patient should ever be made to feel untouchable. One of the lessons I've learned from that is it's important to touch patients. So I started with telephone. This is going to happen one way or the other. The issue is how it's going to happen, both in terms of the technology and otherwise. But I would also, the other great challenge is how it's going to touch patients to make it work. So I feel privileged to work where I do because I work with people for whom that's their mission, to make a difference to the veterans. Thank you for listening.
Well, thank you for the opportunity to be here. I should note at the beginning of my comments that while I worked for the Indian Health Service for 20 years, my comments today do not necessarily reflect those of the agency. So I've titled my talk, A Difficult Crossing, the Diffusion of Telehealth Innovation. And this painting from the 19th century captures some of the difficulty for me. We could spend some time looking at who the actors are here and metaphorically relating that to our current situation, but I won't dwell on that because I'm very interested in what's on the other side for where those folks were trying to go. When I think about the workshop that we're having, entitled The Role of Telehealth in the Evolving Healthcare Environment, I guess I would have the same question. Where is it that we're trying to go? I believe that we would all agree that the widespread adoption of telehealth is an important and major goal. And we've tried this in different ways. We tried it the noble, albeit stealth, nighttime way with reimbursements across the country, aka Washington on Christmas night, 1776. We've also been trying it this way, which is the follow, hold, and try to edge ourselves across the bar, moving from where we've been to where it is that we want to go. And an issue comes up, obviously, well, why is this crossing so difficult, and are we crossing the way that we should be? Well, there are many answers to this that we've seen over the past 15 years. The current answer, which is the no-brain answer, which is, well, it's about reimbursement, and that telehealth payment should be equivalent to in-person care, and we've heard that multiple times in the past 2 days. But I would remind myself, and I'm sure many of you would agree with me, that the widespread adoption of telehealth isn't really our goal. These sorts of ideas, quality is really our goal, as conceptualized here by the Triple Aim, which I would remind us is not just about the experience of care and about decreasing the cost, but about population health. So, a question that I like to ask, and we've tried to ask inside Indian Health, is how can telehealth innovation help achieve the Triple Aim? Would that it would be like nature, where we talk about leapfrogging, but in nature the frogs have sticky things on their pads and they can move from one plant to another with grace and ease. Would that it would be like other types of crossings, where lots of money, good planning, and very careful engineering gets us from one side to the other. But it's more like this. And it's more confusing, and it's more difficult for us to even know what it is we're trying to cross. The Indian Health Service and Indian healthcare in this country doesn't have all of those cloverleaf highways, but it has its own confusing conundrums that are very similar in terms of crossings, and those apply whether they're in cold environments in Alaska, warmer environments in Arizona, and by the way, in all those photos, there were patient homes that were there. The Indian healthcare system is a system of some 600 plus facilities, some hospitals, but lots of outpatient facilities, some full-time and some part-time across the country. I would call your attention, though, to two key parts on this slide. The arrow points there to the tribal components. Over half of the Indian health system in this country is under tribal self-governance. So partnerships, collaborations are critical, and tribal governance is an important part of that. The other is that this is just not about rural, it's mainly rural, but Indian healthcare occurs in urban environments. There are some urban facilities, both that are urbanly funded, and as well as some of our hospitals. And really importantly, and this is a differentiating point for IHS and Indian Health to the VA and other federal partners, for all those facilities, over the half of the operating budget of most facilities comes from third-party billing. So business models matter. As was noted yesterday by Dr. Nesbitt, telehealth is not new to Indian Health. This is a picture of the van from the StarPack project from the 70s, which was an interesting collaboration in the early 70s that was applying really some of the same basic precepts of care that we're talking about today. Since that time, and really in recent decade, we've actually embraced lots of new tools on our way to having new service models. And I'm not going to go through these that are listed here, except to note with this nice little graphic that the service model is key, and that there aren't really new service models, except for radiology, which I'll remove from there, but that there are emerging service models. And this is a challenge that I'd like to discuss with you. One model does not fit all. It doesn't fit all for many of your organizations. It certainly doesn't work for us. Some of the models are driven by necessity. Dr. Andy Narva, a colleague of mine, now works at the NIH, but he was the nephrologist in the southwest of the IHS, and importantly, he was the nephrologist for Zuni. And when he moved to DC, the Zuni healthcare system did not have a nephrologist. So by necessity, the tools became something that Andy was willing to embrace, as well as the community. Many of the models for these new services rely on new partnerships that we may not be accustomed to. Yesterday we heard about Coconino County, which is where I'm from in northern Arizona, second largest county in the U.S., a county larger than 9 states with one regional referral center. But it sits right adjacent to the Navajo Nation and the Hopi Nation. And so new service models and require new partnerships, and we're actually working on those right now in shared models with folks in the region for psychiatry and other services. Some models add very robust efficiencies. This is a great slide from Stuart Ferguson that looks at the speed of reply for cases done in store and forward consultation across the state of Alaska. And I don't have time to go into this, but it shows just dramatic improvements in efficiencies. In some parts of our system, however, those efficiencies can't be reached because the models aren't integrated into the care systems. This depicts the care approach in the culturally appropriate PDSA cycle in the Chinle Service Unit on the Navajo Reservation. And new types of innovation that don't work in this type of model and depiction are not easily integrated. Many models require new commitments. We've run telenutrition services from northern Arizona for Indian Health sites in multiple states. That commitment was there for 4 years. We did thousands of interactions. That commitment recently went away, and so the ability to continue with that model did with it. But most models, as we know, don't happen without lots of effort. The IHS has its own teleophthalmology program for retinopathy screening. This is based on great literature that shows that it improves access to screening and it improves access to laser treatment for folks who need it. The costs are lower, the actual care and the screening is better than in-person exams. But you can look at the slope of the uptake of this, and over 12 years, while we've made significant inroads, it's taken a while, and we're only finally perhaps reaching the inflection point. Unfortunately, eye screening rates across Indian Health, while they've improved in certain 20% of the facilities that have embraced these tools, they still have lots of room for improvement. On the plane out, I reread Roger's book, Diffusion of Innovation, and I think there are lots of interesting lessons for us, and it was very helpful for me to reread that because these are some things that aren't new, and they're maybe not new to us. We know that many care models using telehealth innovation don't diffuse the same way. Yet we still talk about telehealth innovation in these certain buckets of tools and how we can consider their use, real-time, store and forward, and remote monitoring. And I guess I would ask that we consider, especially when we look at diffusion, a new stratification. We can consider innovation that stratifies or that integrates better into conventional models of care that doesn't require fundamental process and payment change. Radiology perhaps is an example of that. There's innovation that requires important but non-fundamental change within certain closed systems in the U.S. And some specialty care in organizations such as Kaiser or the VA, I think, is representative of that as well. But there's telehealth innovation, and that's a lot of what we've been discussing the past 2 days, that requires fundamental change, especially for open systems that are collaborative in nature and not within particular organizations. And chronic care coordination, and I'll chat about this in a second, after hospital discharge falls, I believe, into this category. So from those thoughts, I'd like to wander in front of you very carefully with the next thought. And that is that telehealth-enabled care is not necessarily the same as in-person care. It shouldn't be. And because it's different, and the innovations are different in different care models, we shouldn't expect that it would be reimbursed in the same way. And I don't think we've done our job in working about new models of reimbursement. As I've already noted, in some care models, there's no in-person option. So I think reimbursing the same way across video makes sense. For some care models, telehealth innovation does not add value. If the care model does not change, entering into a new tool actually doesn't bring value, and there are lots of examples of that. For certain care models, it may be just as good as conventional care, and there's growing literature on this. And importantly, sometimes it's actually better. But I don't think we should try to push this big rock of telehealth up the hill as if it's just a single rock. It brings risk to it. One of the risks is that we could confuse ourselves and the folks we're trying to speak with that this is apples to apples when they may think it's apples to oranges, or even though they're both healthy, apples to tofu. And that creates difficulty in bridging the gap of understanding across different parts of our care teams and regulators. And I would call attention to this article from 2010 entitled Telemonitoring in Patients with Heart Failure, published in the New England Journal in December of 2010. The conclusion was that among patients recently hospitalized for heart failure, telemonitoring did not improve outcomes. The general conclusion, perhaps from pairs and from others who may not have read the full article, telemonitoring for heart failure, care coordination models don't work. Well, when you dig inside the discussion of the article, there are two very important points. The first is that this trial, which was multi-site, built off of a single-site trial, where they found a 44% reduction in the rate of readmission, which was associated with significant cost savings. These folks were looking for scale, and they did not try to scale based on a single skilled nurse case manager, but via an automated monitoring system. So one can step back and say, well, is there an alternative conclusion that we should generally reach from that study? I believe there is. The non-relationship-based model didn't work. But the relationship-based model that this was built off of, that wasn't published in the New England Journal, did. We're running a project right now in northern Arizona trying to learn from that lesson. It's called Care Beyond Walls and Wires, a collaborative project between private industry, Indian Health, community health centers, and the Flagstaff Medical Center. And it's really built around patients. This is Garrison Begay, who's a patient who's part of the project right now. He lives in a very remote part of the Navajo Nation. And via smartphones and wireless tools and 3G signal that actually reaches near to his home but not his home, he can stay in communication with Kelly DeGraff and other care coordinators after discharge in his community. Some basic approach to care coordination that we're familiar with. We tend to emphasize, when we talk about it, especially in meetings like this, the tools. But this is about the relationship between Mr. Begay and Kelly. And I'll remove the tools, and it's about the relationship and the communications they have on a regular basis that's made the difference. So much so that on an NPR story, Mr. Begay noted, it's just feeling that backbone there to have support. You know, it does touch you emotionally because who else is watching out for you? So I would ask us, and I would ask us in a research location, when we think about research, what is the value of relationship and connectedness in some of these new care models? We've put together a mock-up model of this. It's not new. Certainly this has been in social science literature. When we think of innovation in healthcare, we're actually trying to trigger certain intermediate behaviors and activities such as activating self-efficacy, self-management, and med-compliance to achieve the triple aim. But relationship support, whether it be social supports, behavioral health screening and support, or health coaching, as Bill Applegate talked about yesterday, is critical to opening that spigot, we think. And there are research agendas in that I would like to see us focus on. Some final considerations then. I think we should stratify telehealth innovation differently and then identify, learn, and disseminate diffusion models accordingly from that. We need to support more collaborations in open health systems that work towards achieving triple aim for their population, such as that I was describing in northern Arizona. By an open system, I mean one that is between different health organizations that have different business drivers and motivators. We can then study the role of connectedness in regional partnerships to improve transitional care for patients with heart failure, especially during that critical 30 days after hospitalization. Finally, I believe that we can actually support care model change at a larger scale by focusing on key locations like Indian health facilities and community health centers. And I believe that a national project in this way is an ideal way to study the effect on triple aim of systematic uses of telehealth innovation. And that can lead to policy and legislative change. Well, to close, changing care models is a daunting task. And change can challenge and does challenge our care teams and our policymakers. But as my colleague Dale Alverson points out to us standing next to the sculpture of Albert Einstein outside this building, we stand on the shoulders and we stand next to giants. And as my mom and my sister remind me, generational change does not always have to be difficult. It is different. We are different from our parents' generations. But in fact, we can have loving and continuing relationships with them. And that I'll close. Thank you.
Good afternoon. I want to thank the Institute of Medicine and National Academy of Sciences for this very timely and much needed discussion. And I want to also acknowledge it's an honor to sit on this panel with Dr. Carroll and Dr. Darkins, who provide such leadership in pushing telehealth on a national basis in a public manner for our veterans and our native patients. I'm a psychiatrist. I'm based at the University of Colorado, so I'm going to talk about relationships and echo some of the comments that Mark made. I do wear several hats that Dr. Manson mentioned, so this is my get-out-of-jail-free card. I'm solely responsible for the content that I'm going to discuss. And to give you a brief overview, I've spent the last decade focused on work in clinical video teleconferencing, telemental health, working with native and non-native populations in rural areas, including veteran and non-veteran populations, doing programmatic clinical and administrative work. And so my comments are coming focused out of those experiences with live interactive video conferencing predominantly. And I think, as we've heard several times over the last day or two, that it's really not about the technology, but the technology is our conduit and our bridge to that relationship with the patient to provide care. And in a lot of ways, even in non-mental health fields, some of the most important treatment we give is that relationship and that healing relationship between a patient and a provider. And that really is the core of telehealth services that that at least I have been involved in. But that doesn't happen without a series of relationships that need to occur to allow a provider to see a native patient in a rural community. It is very, very complicated. And in fact, although that relationship is critical, it is not the most important relationship occurring for successful telehealth clinics. Actually, the most important relationship that I have seen is the relationship between the service and the provider and the community they're working in. And if that relationship doesn't exist, then you don't have a clinic or a service. Embedded within that is very important organization to organizational relationships. And particularly for native patients, you're talking about eligibility across multiple systems. And there is a lot of data and research that show that native patients in particular use various systems. Native veterans that I work with might get their primary care from the IHS and choose to get specialty mental health care from the VA, for example. And then finally, in specific programs, you also, which I'll discuss, have relationships, both internal and external, that need to occur for successful clinical interaction. Jumping back a little bit, there's been some discussion about mental health, but I did want to make a few comments, particularly about telemental health. One, in the field of mental health, I would argue we have a very unique fit for telehealth, and that most of what we do clinically can be accomplished in some form over video conferencing. And this has been shown in the growing literature over the past decades across age groups, across populations, and across treatment, although certainly we need to grow and nurture that literature. And particularly in the last 5 years with the emerging technologies of direct in-home video conferencing, mobile health, and web-based care, which are changing how we interact with our patients. Obviously, we've heard the particular relevance of telehealth and telemental health for special populations, in particular native communities with geographic barriers to access, as well as cultural and institutional barriers that may prevent them from accessing care. I would argue also that although, and there's been some talk about randomized controlled trials, there is certainly a place, and we need to do more of them in the field of telehealth and telemental health to demonstrate that our treatments are as rigorous as any other treatment, which I believe to be true. But we also need to begin taking more nuanced approaches, which I'll talk about in a minute, trying to understand this tool of technology and how it interacts in the relationship. So rather than just asking, is it as good as, is what are the differences? Because each of these tools have strengths and weaknesses. And there's appropriate pairings of technology with diseases and populations, and I don't think we understand in a systematic way how to make those pairings and how to address that. What I'm going to talk about for the next 10 minutes, if it piques your interest and you want some more information, if you go to www.ruralhealth.va.gov, there's a video that tells the story of rural telemental health clinics for veterans with PTSD in some of the words of Native veterans in the Northern Plains. There's also a recent article published in the Journal of Telemedicine on a review of some of the data I'll be presenting, and the people have already talked about some of the basic guidelines that are available for telemental health, and there's a number of general public training sites. This one, www.tmhguide.org, was developed by our program in conjunction with SAMHSA to help introduce clinicians, administrators, and patients to the use of video conferencing and clinical interactions. So let me shift gears back to that diagram, and let's start with the patient-provider relationship and talk a little bit about what we know both clinically and from the research data about the strengths and weaknesses. And as Mark pointed out, there may, and there's good data that there are some situations when telehealth may be more effective than face-to-face visits. So let me give you an example. I do some work with the Cook Inlet Tribal Council, and I treat patients in Alaska from Denver. And when I'm working with female natives who have history of domestic violence or post-traumatic stress disorder, they often tell me it's a lot easier to begin our work together over video because of the feelings of safety and distance they have in working with a male provider. As they get to know me and we develop the relationship, then that necessity, especially in the first few visits, of feelings of safety goes away, but I've been able to develop a trusting relationship. There's obviously counterpoints to that distance, which the biggest one is loss of cues and the perception of emotional distance. And again, I think if you look at the literature in the 5 to 10 randomized controlled trials in telemental health, you see equal outcomes, but there are some hints that there is an impact on the doctor-patient relationship and the clinical process. And we do not know how that translates into how that impacts ultimately our clinical outcomes. And I think that's very important to understand. I think clinicians working in telemental health will tell you that it is true, that it is different than seeing someone face-to-face. And the good clinicians understand that, and the good systems understand that and make adaptations. There are a lot of different adaptations to bridge those types of gaps that come out. In our programs and working with Native communities, we do a lot of contextual training. One of the things that happens is providers often are from urban areas. And the amazing thing about the environment that we work in is you can be getting lunch in downtown Denver. I can drive to my office and boom, I'm working with patients from Spero, Alaska, which is a very different environment that I'm sitting in. And you feel much more disconnected doing this over video. So unless you make a real effort as a provider and a system to understand that environment and the issues impacting the patient, even on a weekly basis in terms of the events occurring in the community, you may lose touch with what's going on contextually. We also have used cultural and clinical facilitators. So for instance, in a series of clinics we work with the regional VAs, in addition to having a clinician, in each of our clinics we have what's called a tribal outreach worker. That is a Native veteran who lives in the community, who does our scheduling but bridges the rapport and gap and helps us bring patients in to the system that traditionally may have been reluctant to get care from federal healthcare systems. I know this both from data and experiences from patients where we've had Korean and Vietnam veterans who had previously sought no care for mental health issues that came in not because of some stranger coming over the video from Denver, but because of the community member involved in the clinic and getting them in. And so that's one adaptation at the patient and provider level. Additional adaptations include collaboration with traditional healing, which helps acknowledge, again, that local context of the patient's treatment, which is so critical. One of the other things that I observe is some of the biggest cultural issues I often see. I'm involved in a training clinic that teaches residents to work with rural veterans, and psychiatric residency is not the cultural issues between native and non-native peoples, but the urban-rural difference. It can be a real divide, and a lot of our providers are urban providers who have not spent time in rural communities. So again, using some of these tools and training to allow them to learn that rural language so they can communicate with their patients is extremely critical. So that are some of the salient issues at the patient-provider level. But moving up, telehealth requires this program-to-program interaction. In some ways, I think for mental health, which has traditionally been siloed, it's a good thing. So when I am working in the VA to develop a telemental health clinic, I'm working with IT. I'm having to coordinate with the local primary care services. So you're looking at both internal and external programmatic collaborations, which may not traditionally happen in the course of clinical care. And in some ways, it's a real benefit in terms of having to work together programmatically. What it does is it almost forces an increased level of coordination, continuity, and consistency in the care and leads to more holistic approaches. But I think we need to systematically understand and begin looking at what the 21st century healthcare team is. Because it's really, and traditionally, 20 years ago for a mental health provider, it was often just that mental health provider. But if you're working in telemental health, that team now is likely a mental health provider. It could be, for instance, in the VA system, it will be the IT service. It will be your local telehealth coordinator for the facility you're working with. At the Ensign Clinic, it may involve primary care, a desk clerk, an outreach worker if you're working with tribal communities. And so our conceptualization of healthcare teams has not kept pace with our technologies and the models that are delivering these technologies. Finally, concluding the organizational issues. As our programs have learned to be successful in implementing new services in Native communities, it's forced us to do multiple organizational collaborations. One of our clinics had 6 different partners, 2 VAs, a university site, Indian Health Service, and 2 tribal partners to put this clinic together. And I can say multiple systems of care are possible, and they're highly desirable at times. They bring together resources where one institution doesn't have all the resources. As you bring the different players together, you're able to have a full menu of resources for your patient. Like I said, at the program level, it increases care coordination, and also when you have multiple systems, you also have maybe additional pots of resources and funding. On the challenges side of that, bringing the right partners to the table is often critical, and having the wrong configuration of organizational partners can sabotage any developing service. Obviously, trying to get technology to talk between systems can be a critical issue as you cobble multiple organizations together. Dealing with multiple compliance and regulatory issues across systems can also be very challenging. And on the flip side, identifying who's going to be the primary funder when you have multiple systems involved and who's reimbursing for which parts of which programs or service can also be an issue of discussion. And so, as I said, some of the fundamental lessons we've learned is that multiple system collaborations can be highly desirable. You need to know the local ecology, and it's very important to put together the right communication and collaboration process and holding environment to be able to do this work. And ultimately, finding a way to take those organizational collaborations, which often start off based on individual relationships, which can be so critical in Native communities, but in all healthcare interactions, and systematizing them. So when your champions move on and people move on, you don't lose what you have built. And so I will just conclude where I started, is getting back to this model. I think that we need to do a better job of investigating, exploring, and codifying these models that are successful at these different organizational levels, and understanding the importance of the impact of the relationships and how things are successful and or how they do not work, as well as understanding, particularly on the patient-provider level, how the technology affects the process, either positively or negatively, in the appropriate adaptations to make sure that that as we develop these services, we're keeping our eye on enhancing the quality of care and enhancing the access and fulfilling the promise of telehealth in those areas. So.
Well, a heartfelt thanks to all three presenters, Adam, Mark, and Jay. I think many of the things that they shared are echoed in part, perhaps, from throughout our discussions to date, but pointedly underscored in a number of ways that perhaps we haven't acknowledged as explicitly. I think that this emphasis on relational building, and not just at the provider and patient level, but throughout the hierarchy of relationships that underpin, and actually I believe it, eloquently stated by all of our panelists, relate very directly to the success of the encounter as well as the service long term. Questions from the audience? Dale.
Just want to say, it looks like it's on. I don't know if you can hear me.
We can.
Okay. First of all, as always, with each of these panels, it just keeps getting better and better. Right? My question is really this, is how do we break through some of the silos when we look at great opportunities, like we see models in the VA and the Union Health Service, and combining those with the Department of Defense and so on. How do we break through those so-called virtual firewalls where we really have much more of a collaborative relationship beyond just those organizations that, Jay, you were talking about? But, you know, how do we take advantage of that? Because the VA has just fantastic models of service, and yet many times it's hard to translate that over to the civilian sector, in which, say, our veterans reside as well, and we seek care from other organizations. It might be a Native American who uses the Indian Health Service, might use an independent tribal and uses the VA, and then uses the public sector, private institutions. So I guess my question is, how do we move it forward so that we break through those firewalls and really have much more of a sort of global system of care coordination for our patients?
Well, I just might answer first that I think recognizing that the system, the differences in the system, the organizations, including their mission, is critical. There is an MOU between the IHS and the VA for exchange of information, tools, experiences, etc. But looking at the respective missions of the organizations, it has guided the focus on the service for American Indian veterans. So that's why I think stepping back and looking at why things diffuse well in some systems and not others, based on criteria already published, that can actually serve as guideposts for us, can be helpful, so that we don't set up some expectations of diffusion in some systems because they're very different. And a closed, these terms are clunky, but a closed versus open system is very different, and we're really being challenged now to translate lessons learned often and great work that's been done in some systems that tend to be more closed. That's a bad term, but within organization, we're challenged with translating those into interactive partnerships, and we certainly haven't sorted that out.
I kind of see the answer is growing from the top and growing from the bottom. An example of growing from the top is the MOU and the work that's being done, the exchange of information, education, and there's growing momentum as an example in that MOU. But also at the local level, what I have seen is things happen when you have people have a particular purpose. So it's one thing to say the VA and IHS should collaborate more, and there's many areas we could, versus someone saying, I'm in Flagstaff and we're seeing veterans, and how do I hook and use the national processes to develop something that serves the needs of the veterans right here in this area. And that's where I've seen the most success programmatically, and then those go and often grow and feed how we do that at more structural levels. So you have both this top down and the bottom up, and in an ideal model where I think learning from each other and facilitating work at each of those levels.
And I would say, I'm sure you didn't mean it, but there's a way in which, is this working all right? There's a way in which it sounds like you talk about silos, as though it's being pejorative and saying it's a way in which people sort of stay in their own entities and they don't mix outside, and there's some restriction to doing it. I think I started off with the preface where I was trying to say earlier in my talk, by this is about developing networks. So if you develop networks, it's around large, standardized, interoperable procedures. So the VA has lots of collaborations with the Indian Health Service, and many of these collaborations come up and go down. A large network, the difficulty is when I say the devil is in the detail. When somebody comes along, basically, they've been doing point-to-point telehealth, and they have no process in there. Relationships are terribly important. I'm not diminishing the value of relationships, but when these ultimately become large networks, it's about process. So there are two sides to this. I mean, we end up in a world where, let's start with the clinical process. Clinical process varies. So part of this is, within an organization like the VA, it isn't, you could say the same thing. We have 152 hospitals. Part of building these services is developing a way in which doing these things links 152 separate pieces. So the clinical entities have to be interoperable. We work in an environment where many of the technologies we use are not interoperable either. We work in an environment where telecommunication is not ubiquitous. There are issues that come up with privacy, confidentiality, linking things. The other thing that I haven't been here all the time, but I haven't heard of in particularly, is this builds, from my point of view, on a computerized patient record. So one definition you could give of telehealth is a multimedia patient record. If you don't have the ability to exchange information, the ability just of video is a relatively limited. This is about decision making for patients, and it works because you've got that. The other thing that comes up, the VA is no different from anywhere else when it comes to how things are funded. The programs have not been mandated from on high, and neither is the centralized funding. I mean, the value proposition to growing these programs has been largely the benefits to access and the benefits to saving locally in terms of how things were done. I won't spend a lot of time because it would take up a lot, but over the period of the home trial programs, it took us nearly 5 years to build up the data to be able to develop an internal allocation system that means there's now incentives to be able to do it. So this is, I would just put to you, this is hard work. And part of it is not saying we've got these silos, we've got making these links isn't about saying, well, let's just shake hands and work. It's about saying, we've got to really work hard to find out ways to have interoperable technologies. And I would think to say, overall, how does this happen? I think how we do what we do successfully is this, which I think picks up my two colleagues. This is almost all about community building. So, I mean, I think there's a way in which, if we talk about there's the private sector and the federal sector, at least two entities somehow are different. We have to find a way to build a community that links between the two. And that's the real challenge. And I think people who are good at this are really good at building communities.
Thank you very much. I don't know if this is on.
Yeah, I think it's out of batteries. I'm going to do the other one.
Well, perhaps I can just talk loud. Thank you very much for your stellar presentations. I'm Dr. Spero, I'm a consulting medical advisor to NASA. Very much appreciated some of the thoughts about networks and collaboration and linkage. About 10 years ago, NASA wanted to create its own electronic medical record for all our field centers, and we thought we would work with our public partners. So we went to the IHS, we went to the VA to assess if you had any occupational health modules. Unfortunately, we didn't find any, and we've had to create it. So perhaps the reverse exchange where NASA might be able to provide to the VA and IHS our modules and to see if there could be increased collaboration. So I think that's one important point. Another is to look at the issue of databanks. I know yesterday we talked about studies and we talked about a comparative effectiveness research and PCORI and the impact with the Affordable Care Act. The challenge I see with the VA is because of that quote-unquote closed system. Do you really envision that we could create these partnerships where your data could be used in registries for point-in-time evaluation, which could certainly impact not only what you have within the VA, but within the private sector?
I mean, I think we're talking about a world, the answer is, I mean, do I personally think so? I personally think yes. And in terms of the VA, is certainly working towards how information is going to be shared in exactly that way. I think it's one of the challenges for healthcare organizations, not just in this country, but worldwide, is how one gets that kind of linkage between it. So, I mean, I think the answer to this is the time when health information becomes more commoditized. I mean, we have tremendous diversity of systems at the moment. But is this going to happen? I certainly believe it's going to happen. If it were in my sphere of influence to make it happen tomorrow and I had the capacity to do it, I obviously would. But there are the challenges in the meantime. However, putting these programs together, why I said it takes 68 separate things for us to develop a program, is because it is the devil in the detail, is you have to piece this together from imperfect things at the moment. If it were that it would just fall together and happen, we'd be able to do this a lot more easily and we wouldn't be having the discussions we're having now.
Well, and I know the IHS would love to chat about the ability to exchange bidirectionally and continuously in terms of systems development. This has been a history with the VA for information system development that goes back 30 years, and from which the graphical user interface for electronic health records was built. It's very interesting when you talk about the occupational health. In my new role in the region of Northern Arizona, we can think about outreach and collaborations in the region, which we're doing, and thinking of new models of care, but not only are 30% of the admissions and discharges at Flag Medical Center Native Americans, and making it the largest Indian health facility based on average daily census than any IHS or tribally run facility. But so many of the employees are Native American. And so if we step back and think creatively, maybe Flagstaff Medical Center and its employee benefits program should be thinking about use of such tools and get outside the box. And that's some of the things we're trying to do.
I'd be curious to hear a little bit more from each of you. We've talked in regard to other aspects that have been anticipated but not really closely examined. And that has to do with how have you thought about in your respective systems bringing into play local, regional, and national leadership, not just within your agency, but those who can champion and advocate the context and opportunities for you to pursue the networking you're talking about, Adam, across the multiple entities. Encouraging seeing the value of certain things. For example, information, knowledge is power. In many Native communities, for example, there's a great deal of reticence about sharing that for fear of its application. Adam, seems like the VA has done a marvelous job in figuring out, albeit with enormous amount of effort, what kind of information is needed and to apply it quite directly and regularly to the improvement of the quality of care as well as the accountability of effort. So I'd be really interested in how you've thought about educating and bringing into the sense of community, not just providers, not just administrators, but also key decision makers from outside of your agencies. It seems critical to the success that each of you have had.
I'll start down here. Okay. Well, I would say, and particularly in the work that we do in the VA, both the VA system leadership and the tribal leadership has been critical, and in each community that we set up telemental health services, we go and we have discussions with the tribal council and engage that leadership. We also then engage the local VA leadership as well. And so that has just been part of the process it's really hard to move forward if you don't have that local, regional leadership buy-in. And then on the national level, it's through venues like this where you're able to discuss and promote your model and get access to decision makers and look at and also identify others that may have interest in taking that model and expanding it. So, for instance, in the telemental health clinics we run for Northern Plains veterans, that's started off in the Northern Plains, the VA region called Visit 19, but in the coming year we're going to be helping 2 sites nationally outside adapt that, and that's come about because they learned about it through these leadership decision types of discussions and have been convinced that at least for their regions and areas that model may make sense for some further adaptation.
Well, in the example you cite, to give credit is due, was a little bit of venture capital risk-taking on the part of the VA, particularly with respect to Adam, having seen the opportunities and deciding to invest in seeing what possibilities might be realized in that regard, and thus generating a series of small but early effective models that then can serve to inform other advocacy efforts. Adam, I saw you leaning forward, though.
I think Dr. Manson's referencing that the first clinic of this telemental health service was on the Rosebud Sioux Reservation in early 2000, and it was Dr. Darkins' office that provided the funding, which was really kind of a national office, and that was going through the process really with Dr. Darkins' resource support and then getting buy-in with the local VA leadership and then, of course, the tribal community as well, working off Dr. Manson's decade-long collaboration with the Rosebud Sioux tribe, and so we had those relationships with the leadership. So that, I think, the example you're referring to.
Well, I'll answer the question in just a second. I'll just say in relation to that, I mean, the reason why it was a privilege to be able to help support that program at the beginning was having been down to New Mexico and been on some of the Pueblos and seen the health need. So I think coming back to the driver for this, the driver is really a public health need. It's really an understanding of delivering care. So it's something where it wasn't a funding off one project. I must say this is something for which I feel very passionate, personally, that we develop. I think, I mean, firstly, being slightly humble here, I'm not exactly sure how to do it. If I could do it, I would certainly be doing much more of it. I enjoyed very much listening to the panel on what's happening in the States, because I think part of this is it needs a large, vibrant community who are thinking the same things. So I certainly think to see large state programs or active state programs is going to really be very helpful to form the nidus of how these things come together. There are decisions which sort of lie outside one agency, which is if this is about population health at a state level, there's a way in which there are multiple resources, and are there ways in which those resources can be pooled and used in different ways? I mean, if there are going to be networks for telehealth at a state level, networks in a VA, some in the Indian Health Service. Now, there are complex questions to get there, but I think that the discussions have to be around those groups. I don't exactly have the answer. I mean, what I do have is, having built over time if you like, a community within the VA, which has been building a community from nowhere where it's at regional levels. So we certainly have a regional capacity to do telehealth and help grow telehealth. People's primary mission is obviously, and they're hard-pressed at the moment to deal with what they have for veterans. But I say one of the things about the mission of the organisation, it has that mission, firstly to deal with veterans in other organisations and the private sector. So, I certainly would put on the table that we have ways in which we do have regional representation in ways that I would be very happy to see how we can do ways to broker relationships and establish what you're talking about. And suggestions would be very welcome.
Thank you. I submit to you that that's not been part of what we've systematically investigated with respect to the diffusion, going back to your earlier observations, Mark, of the technology as a means for improving health care. Nina and the other gentleman, I saw you at the microphone earlier.
Go ahead.
That's all right. I just wanted to ask Dale's question in another way, if I could. Adam, I've known your work for years, and Mark years, and Jay's, and how do you think we can get CMS to accept your data and your work and your history in this area and not ask us to reinvent the wheel and prove this over and over and over again? All the way back to the ARC meeting, I think 10 years ago when, Mark, you presented, you have a gold mine of data that we don't have to prove this over and over again. And they're valid, statistically sound studies with amazing results. Help us understand what the reason is we can't get CMS to just accept that. I don't think it's a silo issue, but I understand it's more of maybe a captured population in that the veterans access most of their care through VA facilities. The natives and tribal groups access most of their care through Indian health centers. The Medicare population goes all over, but there's got to be some way we can capture the value of what you've done and convince HHS agencies to accept that somehow.
Well, thank you for that question. The IHS has actively been dialoguing with different offices in CMS about exactly that. National coverage determination for Indian health sites, building off of the coverage determination in Alaska, which has included store and forward, and the fantastic data that we actually have, both in terms of outcomes, process, and cost. We didn't show any of that data, but there's phenomenal data for that. There have been some bills that have been proposed by U.S. senators. There was a particular bill, in fact, that would have authorized for community health centers and Indian health sites this was a few years ago, but for reimbursement for telehealth within that model of care. I think it's a great idea. ATA supports that. ATA has that language. In my new non-federal hat, I'm happy to partner with anyone in this room who can help advocate and help move that forward. I believe that's an ideal arena for us to move forward, and to move forward in a partnership, say with CMS and others, to evaluate things that make sense to them going forward. So we are very interested in that, but and there are active dialogues right now, but it's a little uncertain where that may lead.
And I would say, CMS has been actively involved in telehealth since its inception and still is obviously interested in what happens with telehealth. So I'd sort of put it back and say, what exactly are you asking here? In the sense that it seems to me part of making this work is one has to actually take responsibility to make it happen. So if you're asking, do I personally, because obviously the department I work in hasn't got a position, or at least I can't talk to it, but my personal views on this are as follows. I mean, there is no systematic way telehealth is currently being done. So we do it systematically, and it's hard work to systematically do it. We've seen where things have not been systematized with home telehealth, a 40% increase in utilization. So I think there's an issue about what is one going to describe, firstly. And then, secondly, I mean, I think the other thing around it, which we have to acknowledge, is this is not the standard way of doing practice. I mean, I certainly believe if somebody suddenly said there's a way in which this could be done tomorrow, there's a tremendous clinical change management piece that has to be done with this as well. So I think that I'm not sure what solution you're suggesting should go forwards in terms of suddenly be adopted. And last of all, again, I mean, my background in telehealth, I said from the beginning, has been about solving problems. So I've never thought about where's the money going to come from in terms of from elsewhere, other than saying this is really about how you change clinical process and how you make it actually value and work. So I think that, and lastly, one has to say, CMS has to be driven by, as everything else, by evidence. And so more widespread than just our organizations has been research on telehealth, which has been going on for 15, 20 years. And we're still answering the same questions. So I would say one of the things I would, as again a personal observation, is I think that this is about networks, and there needs to be some work done with networks of a larger size to be able to look at it before one can talk about models which are transferable.
Thank you. Last question.
Yeah, Mario Gutierrez from the Center for Connected Health Policy. I definitely want to echo what Nina is saying here. For example, the Health Buddy program of the VA has been demonstrated to be incredibly successful with working with your clients at home. How that information and that data and that success can influence Medicare policy, for example. They're both federal agencies that can learn from each other, and I think it would really advance what we're talking about here in Triple Aim. But the question or the issue I'd like to pose is there's another aspect here of the benefits of telehealth that are being surfaced, and that is the relationship between the client and the provider. Having worked with tribal health programs in California for many years, mental health, behavioral health is one of those critical areas of cultural competency and the traditional values that go into mental health, so to speak. And so I'm wondering if you could speak to that point. Have you seen in your work, either Jay or Mark, both of you, how telehealth can incorporate those cultural values and even to use traditional healers in the practice of assessing?
So in the clinics we run in the Northern Plains, we have, depending on the VA facility, both formal and informal relationships with traditional people. So we've had ceremonies and blessings. I was actually blessed and a clinician to work in a community over video conferencing. The healer felt that could be done. In one of our clinics, we have a referral system, and again, not all clients want to follow traditional medicine, but we have a referral system where we'll refer patients that are interested to healers for sweat lodges to help with PTSD, and occasionally those healers will come in and communicate and discuss with the patient's permission things going on in the treatment. So we've done that, but we've systematically tried in each of the communities to establish either a formal or informal network, and then establish processes around doing that so we can do it in a regular, systematized way. And I think that shows, it demonstrates to the individual veteran that we're taking into account their perspective on healthcare and treatment. But more importantly, it gets back to what I had said, particularly in small communities, native and non-native, it's an indication to the community that that individual provider, that service, that healthcare organization is taking into account the community needs. And you get a lot of credibility. And again, I think that is important with telehealth, because often your representation as an organization in the system may be, a room or a very small clinic. That is a VA clinic, but you're representing a very big organization. And so things that you can do to demonstrate that collaboration and partnership at the community level in the treatment and provision of care is critical. It's certainly, I think there's a lot that you can do there.
Well, that brings our time this afternoon to a close. We now have a 15-minute break from 3 to 3:15. when we'll reconvene here for our next and final content-focused panel, followed by a panel of the Planning Committee to provide some brief thoughts with respect to next steps. Tracy, any logistical aspects? So if you'll find your way back here within the next 15 minutes, that would be appreciated. Thank you.
Thank you.